folks, so today we're gonna keep talking about the depressive disorders. We got through most of them on the last video, but we didn't actually talk about major depressive disorder, which of course is probably the most commonly diagnosed, I would say, and also probably one of the disorders, certainly of the depressive disorders, that folks probably know the best. And so we didn't get a chance to look at that. We also didn't get a chance to talk about suicide, suicidality, and I also want to briefly touch on the bipolar disorders in this particular video. But let's start out by taking an in-depth look at what depression is, that is to say major depressive disorder. Now, we talked about how the depressive disorders, and in fact all of the disorders in the DSM, have what we call a diagnostic criteria. This again is going to be a list, usually 5, 10, 20 symptoms that are possible with this particular disorder, but in order to be diagnosed with that disorder, what you're going to need are a certain number of those, maybe some specific ones of those symptoms. You'll see that here in just a second with depression. And then also sometimes there's other contributing pieces or other criteria that you need to meet in order to get that diagnosis. For instance, length of time that you've experienced this, or some trauma that set it off, or you've been experiencing this since you were born, or it represents a change, right? So there are all these extra things that might also be tacked on, but generally what we're looking for when we're trying to diagnose somebody is that they meet this set of symptoms, that they have enough of these symptoms that are listed for depression that we can go ahead and say, yeah, it looks like they've got enough symptoms that could be depression that we're going to go ahead and diagnose them with depression. So the first thing I want to do is something that's a little bit more awkward, I think, on camera, but that is just read to you the diagnostic criteria. And again, I didn't do this for all of the other depressive disorders, and I won't do it for every disorder that we talk about, but I will do it for several of them because I think, you probably just need to hear exactly what it is that the diagnostic criteria are. And I think just by reading it, maybe I can give some input into some things that maybe if you were reading it yourself, you might not know what that means, et cetera, et cetera. That's probably not going to be too much the case here with depression, but certainly when we move into some of the disorders, certainly the personality disorders or some of the more complex or dynamic ones, I really think that this read is valuable. I'm stressing this here because I have had students say in the past that it's kind of the most boring part of the class, but I do just think it's essential. I could just send you to read it yourself, but I'm not sure that if you weren't able to break down a word or you misinterpreted something, that I'd be able to help you, certainly since we're not in class together. So if you're following along in your DSM, if you have a DSM, this starts on page 160. At the bottom of that page, major depressive disorders. And so I'm just going to read under where it says diagnostic criteria. And what you'll see is there'll be kind of bullet points, A, A1, B, B1, B2, etc. And so we're starting out with A. It says 5 or more of the following symptoms have been present during the same 2-week period and represent a change from previous functioning. At least one of these symptoms is either 1, depressed mood, or 2, a loss of interest or pleasure. So what you see there right away is that this needs to have lasted for 2 weeks or more, and that this needs to represent a change from the person's usual behavior, and this needs to include at least one of the symptoms, depressed mood or a loss of interest or pleasure in the activities that they've done in the past. So that's just the setup, right? That's saying, okay, here's the broad strokes of what we're going to be looking for in this disorder, and then under that, what you're going to see are the actual criteria that you need in order to meet it. So I did skip the part, of course, the very beginning here where it says you need 5 or more in addition to that 2 weeks, in addition to those particular symptom sets. For depression, and this number will change as we go from disorder to disorder. For depression, you need 5 of these. There are 9 total. So I'm going to read through the 9. You need 5. You must have 1 or 2. Number 1, depressed mood most of the day, nearly every day, as indicated by either subjective report, that is, the person feels sad, they feel empty, they feel hopeless, or by an observation made by others, such as the person appears tearful. So again, this is just that first piece where we're looking at the person's depressed mood. That's going to be the first symptom that we're looking for, perhaps for a depression diagnosis. What I found, what I tend to notice in the DSM with regard to the list of criteria, is that the first one, and then kind of ranking down from there, the first one tends to be the criteria, the symptom that's kind of the hallmark of the disorder. They usually put right up front the thing that is the most noticeable, or the thing that's going to be the most familiar or the most defining with regard to the particular disorder that we're looking at. And so here for major depressive disorder, of course, that number 1 is going to be depressed mood, right? That's kind of the first thing that you think about when you're thinking about depression, is somebody is in a low, in a sad mood. What you also see here in this first criteria is that it can be reported. It can be that the person is saying, hey, I feel depressed, I feel sad, I've been upset lately. Or it can also be that the person is noticing it about somebody else, right? I've seen that this person is crying all the time. I see that this person never comes to work. I see that this person always seems to not have been getting enough sleep, right? All of that, of course, is not the depressed mood, but my point here is that the DSM is also allowing in some places that thing isn't necessarily experienced by the individual, but still may also be observed by, in this case, probably a clinician or maybe a parent or somebody else that's close to that person that could say, they'll tell you they're not sad, but they're always in the room crying. They'll tell you they're not sad, but they won't get out of bed, right? Those types of things could also be considered symptoms, not just what the person says, but also what we experience from them. Okay, so number 2, so again, remembering you need either that first one, you either need to endorse a depressed mood or have someone notice that your mood seems to be depressed, or for depression diagnosis, you need this other one, so 1 or 2. Number 2, a markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, as indicated by either subjective account or by observation. Subjective account, again, just means this is my own opinion. I used to really like tennis, and I don't know, now it's just, I don't really want to be bothered with it, right? And so that would be that subjective account, or my buddy saying, hey, Dr. Gordon used to always play tennis with me, and now like I can't get him out of the house. He hasn't been outside in months, and tennis is a good socially distant sport, so he has no excuse. Right, so again, either that subjective report or maybe somebody else noticing it, but basically the idea here is that you have lost interest in the things that you used to be interested in. You're no longer going out and doing the things that bring you pleasure, right? It's one thing if you can't bring yourself to go to work, that might still also be indicative, right? Work is hard and maybe you don't want to do it, but it's another thing if these are things that you used to love and you still won't even do those things, right? And so that's what we're looking at for those first 2 symptoms. Again, remembering you need at least one of those to get the diagnosis. And then you need 3 or 4 of these remaining ones. So number 3, significant weight loss when not dieting, or weight gain, or decrease or increase in appetite nearly every day. So here we're looking for those weight changes. They do give the flexibility here that it might be that the person's under eating, it might be that the person's overeating or has an increase or a decrease in their appetite, but either way we're looking at some eating, some feeding changes that might be indicative of a depression diagnosis. Number 4, insomnia or hypersomnia nearly every day. This, of course, insomnia means sleeping too little, right? Not being able to get to sleep, basically. And then hypersomnia would be sleeping too much, right? Staying in bed really long hours, not wanting to get up, taking another nap, right? Taking 4 or 5 naps a day, every day, type of thing. Also going to be Symptomotor criteria for depression. Number 5, psychomotor agitation. When we say psychomotor here, we just mean movement or the sense of one's movement, right? Do you feel sluggish, right? Whether or not you maybe actually are sluggish. So psychomotor agitation, so that just means you maybe feel antsy, you feel worked up, you feel agitated, right? Or retardation, that means now here you feel slowed down, right? That's that kind of sluggishness that you're feeling. Psychomotor agitation or retardation nearly every day, observable by others, not merely a subjective feeling of restlessness or being slowed down. So I misspoke exactly there. So they're saying here that in fact, this particular symptom isn't something that you can just say you're feeling. This also needs to be something that a person could observe about you, right? You say, I feel sluggish, and you actually are kind of moving really slow everywhere you go, or you say I feel agitated, and the person can observe that, yeah, you really are kind of bouncing around and you can't sit still. So that is to differentiate it from number 6, which says a fatigue or loss of energy nearly every day. So here's that feeling part, right? So if you had somebody that came in and said, listen, I'm feeling really sluggish, I'm feeling like it's hard for me to get out of bed, I'm feeling like it's hard for me, to take care of my kids. And then you also observed that they were moving really slowly and sluggishly, right? That would actually be 2 different criteria there, right? Because one of them is the actual physical, the actual psychomotor, as they're calling it, behaviors. The other one is that feeling of being fatigued. The other one is I feel slow, right? In some cases, you might feel that way and be fine. In other cases, vice versa. But if you've got both, right, they're telling you here to count both of those symptoms. Number 7, feelings of worthlessness or excessive or inappropriate guilt, which may be delusional nearly every day and not merely a self-reproach about being sick. Here they mean, when they say sick here, I do believe they mean the diagnosis that we're talking about, such that if the person seems to be depressed about being depressed, or they seem to be feeling guilty about being depressed, well, that would suggest that they were already depressed before they felt guilty, and so you probably shouldn't count that guilt as one of the contributing factors or one of the making up factors of their depression. But if the person is guilty in general, right, I just feel really guilty about the fact that I don't know, I'm not a good parent, I haven't lived up to everything that I wanted to be in my life, right? If they have this type of guilt, this type of shame, that's maybe more broad, or it could be specific to something, but it's not just a reaction to their own depression, well, then you're going to go ahead and count that symptom as well, right? So they tend to be pretty careful in some cases. Sometimes you'll hear me say that it's a little bit too open, but with something like depression that's been studied so much and so long, what you'll tend to see is that they can be really specific about what counts and what doesn't, right? So this feeling of worthlessness or this feeling of guilt counts when it's not about the depression, but if it's about the depression, don't count it. Number 8, a diminished ability to think or concentrate or indecisiveness nearly every day, either by subjective account or as observed by others, right? So here's another one of those where you can either feel it or other people can notice it, but basically they're just saying that this person has kind of a sluggish way of thinking, right? That their concentration is diminished. And of course, this is something that we see, this is something that we see with depression, which is to say, right, this person has got a lot on their mind, right? They are feeling depressed or they're feeling sad or whatever it is, and you ask them to sit down and take a test, and that's just too much for them, right? That's just something that they're going to have a hard time concentrating to get themselves together in order to do that. Now, not everybody is going to have that same symptomology, of course, but you can imagine certainly somebody who is feeling depressed, who's having a hard time focusing on maybe the things in front of him or her. And then lastly, number 9, recurrent thoughts of death. Not just a fear of dying, recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing suicide. The reason they're giving all of these different variations of suicidal thoughts and all these different levels really is because that is how we're taught to evaluate somebody who comes in and admits or discloses to having suicidal thoughts, right? There are certain levels at which it's okay, it's fine. You know, have you ever thought about death? Sure, of course I've thought about death. Have you ever thought about your death? Of course. I've thought about my death. Have you ever thought about killing yourself? Well, as a thought exercise, right? Like what it might be like. Okay, now we're getting on the border, right? That last question is probably the last one that a person can endorse before the psychologist will raise their antennas. But folks do think about death. Folks do think about their own death. Folks do even contemplate suicide in kind of a mental exercise kind of way, not with any real intent. And often when people do this, it sort of scares them when they're doing it. But they think about it. You know, what would that be like? What if I killed myself like I saw this guy do on the movie or whatever it is, right? So that thought does cross your mind, and so that is fine when a psychologist is asking you that. The next set of questions is when we start to notice that maybe something is going on, maybe something is leading up to perhaps a suicide attempt, and that is well, if you thought about killing yourself, how would you do it? Right? Generally, if we're just having that thought exercise, we don't necessarily give ourselves a plan. You might, and again, this isn't necessarily going to have the therapist, you know, put anything on your record that's really severe or call the police on you or anything like that. But this is the question where we're saying, okay, well, how much have you thought about it, right? You've thought about what it might be like to die. You've thought about maybe the reactions if that death was because you killed yourself. But did you go so far as to say, well, I would shoot myself, or I would hang myself, or I would take pills, or I would slash my wrist, or, you know, something like this? Now we're a little more concerned because it's becoming more realistic. Again, some people just have this thought exercise. So now we're going to ask another question, which is to say, well, so you've thought about how you would do it. Would you have access to that thing, right? So if you say, I'm going to shoot myself, do you have a gun? Or could you get one easily? If you have, if you start going to hang yourself, do you have a rope? Do you have a place that you could hoist that rope, right? All of these different very particulars about, now I'm digging into how much the person has thought about it, right? And if they say, well, yeah, I mean, yeah, I have a gun, and like, I'm just saying, but that would just be the easiest, you know, I don't know, I haven't really thought about it, versus, yeah, I have a gun. Yeah, it's right there by my bed. I think about it sometimes. I mean, I don't, but I definitely, you know, right? And then now I'm seeing this person's a little bit more, I hope my acting's okay, right? Now you're seeing this person's a little bit more invested in that idea. And so I'm asking the person, have you thought about it? And then gauging their response in terms of, well, yeah, I mean, like, I have a gun, or who doesn't have a rope, you know? But no, I don't know where I'd hang it. I mean, I guess if I'm making them think about it, that doesn't count. And so the next question I'm going to ask, right, is if you have a plan, is have you ever gotten close? Have you ever taken the gun and put it to your head? Have you ever thrown the rope over that tree just to see if you could make it? Have you ever gone to that bridge and just looked down to see how far that really was, if that would actually kill you? Have you ever done any of this type of planning for it, right? Whether in your head or by actually going out to purchase the gun when you didn't have one before, or purchase the rope when you didn't have one before, or going to visit the place where it might happen, or going to kind of practice what it might be like to have the gun this close to your face, right? All of these things. Now I'm really seeing, okay, this person has really thought a lot about it. Yeah, I visit that bridge once a week just to, I don't know, there's something about it. I just want to see. I just want to see what it's like. And so you got this person And what we find out is that people who are doing this are actually kind of practicing in their head, right? It makes them less afraid every time they go to that bridge, right? The first time, oh my God, I can't believe I'm here. I'm not ever gonna do this. I'm not gonna do this, but I just wanna see, right? And their heart's beating and it's an experience, right? And then the second time they go, there's a little bit less of a rush. And the third time, and over again, they go until they go, and it's not a big deal. I'm just here. Yeah, why not, Joe? Right? And you don't have that same anxiety around it. Right? You point the gun at your head over and over again, and you say, well, you know, the first time it's really scary, but the 20th time, I could just pull the trigger. Right? And so you have this way that you maybe just slip into that suicidal thought, or you're kind of working yourself towards something, and that's something the psychologist is interested in catching and, of course, stopping. And so one of the last questions that we're going to ask you is if you say, I've thought about it, I have a plan, I have the things that could make the plan come to life, I have the pills, I have the rope, whatever. And you know, whether or not you've practiced, we do see that some folks who are thinking about suicide will practice, other folks don't, they kind of do it impulsively. But the last thing that we will ask is, are you afraid of dying? How afraid are you of dying? And this tends to be really the last leg of that trip, because folks can have all this intent, and again, sometimes, you know, they can still have a lot of that fear and maybe practice so much that they can do it impulsively, right? I'm just going to keep going to the bridge, I'm going to keep climbing up on the railing, and then one day I'm just going to let myself fall, right? It's not that they're not afraid, it's just that they've kind of made this routine for themselves where it doesn't feel like anything anymore. But when you ask somebody, are you afraid of dying, what you're really getting at is how much is that anxiety still in the way, right? We do all have a death anxiety. Talk to Freud about it, but we do all have this death anxiety that keeps us alive, right? It's healthy. The ego wants to survive, so don't do those things. But what you will see with folks who are suicidal is they often get this tunnel vision. Suicidal folks are not, truly suicidal folks are not like what you see in movies or TV shows. Movies and TV shows always try to romanticize suicide. They always try to make it seem like this person had all of these things they were thinking about, and they wrote this really heartfelt letter, and they felt bad for this person, but you know, their feelings ultimately were to whatever. That's not what it looks like. What happens is the person usually just gets so depressed that everything shuts down, right? That loss of interest or pleasure is a really big symptom, such that nothing just matters anymore. I don't want to play tennis, I don't want to get that job, I don't want to see my friends, I don't want to see my kids, right? It's just everything starts to close down. In addition to all of these ways in which the person's feeling bad about themselves and just feeling sad and distressed, right? And so everything is just kind of terrible and nothing makes them happy anymore. And so what ends up happening is they get this real tunnel vision. That is to say, they get this real focus on, I'm just going to kill myself. That's what suicidality really looks like, is it's this kind of neutral, unafraid, unromantic, matter-of-fact decision mode that the person will get in, to where it doesn't matter. Like, I'm just gonna go take care of it. It's not this type of thing where woe is me and the person is really upset, right? Usually the person's very calm, they're very focused, and you will just see that, you know, if you ask them, they may tell you. And again, when we get to that last question, are you afraid? If the person is in this mode, if the person is in this tunnel vision mode, they're probably not feeling much of anything, certainly fear, and they're gonna say, no, it doesn't matter, right? And here is right where we're usually most concerned. That's usually when we're gonna call a hospital, or we're gonna call police to come pick you up and take you to the hospital so that you aren't a danger to yourself. So that is what that really looks like, right? It really does look like this kind of shutting down. I had a client once when I worked in Texas, and we were in a group therapy situation, and there was a guy there. I really liked him. He was a really cool client, and I just mean he had such a charismatic personality. He it was a group therapy, so it was often trying to cheer other people up and checking in on them. And so he had this real kind of colorful personality most of the time. And then one day he comes in, and he's just, he's not talking. He's kind of just looking down. He doesn't look angry. He could come in angry. That was part of his charisma. Sometimes he'd be pissed off about a thing. But this day he was just kind of quiet and calm and serious. And luckily I had a co-counselor at the time who was better apprised and a little bit ahead of me in terms of this type of stuff, and says, I think this client so-and-so is, something's going on. And so we held him back after the meeting and just asked him, is he feeling suicidal? Basically, we got to that. And it turned out it was, it was a good catch on my co-therapist's part to kind of see that shutting down of him, to see that he had really closed himself off and was kind of really intent on doing this thing. And so we ended up getting him some help that night, because he was already in that, it doesn't matter, everything sucks, I suck, so I'm just gonna take care of this, right? That's how people get in those moments. So one of the things that I want to look at as we continue to think about depression and suicide, So one of the things I want to look at while we continue to think about depression and suicide is suicide rates, and then also depression rates. And this is a place where I'm going to start to think about the cultural impacts of some of these disorders, of psychology and abnormal psychology, and the way that can show up in different populations, and the way that can show up in different communities and cultures. So I like this little infographic here. And basically it's just going to give you some overview of depression. I'm not going to spend too long on everything, but there are some things in particular that I want to look at. So about 1 in 10 people at some point or another in America will experience depression. So that isn't to say that 1 in 10 people have depression at any given time. What that is saying is just 1 in 10 people at some point in their life will experience depression if these estimates hold up. About 80% of people that have symptoms of depression are not seeking treatment. And the number of patients diagnosed with depression increases by about 20% every year. And so there's a lot of stuff going on here. I mean, this is a really difficult set of stats to not necessarily take seriously, but to believe, I guess. Only because, of course, a lot of people are going to underreport depression. A lot of people aren't going to go get help for depression. And so I think these stats, one of the reasons, for instance, the stat that I do believe, I would say, is the growing 20% per year. So I do think we're moving towards some more acceptance, some less stigma around things like depression, but I would still say that these are probably underestimates. 1 in 10 in a lifetime actually seems pretty low to me. I would almost think that probably half of people in their lifetime will experience some kind of depression. It's like saying 1 in 10 people in your lifetime will get nervous. It seems a little low. But again, so we're going to take these with a grain of salt, but even at these numbers, it's still pretty high, right? 1 in 10, 80% not receiving any type of treatment, and then growing by 20% each year. So those are still pretty high numbers, even though I think they are probably higher than that. So here we see just a kind of map where the states that have the highest rates of depression are darker in color. And what you see here, this is usually a time where I kind of point at students in the class and I make you try to figure out what's going on. but I will just tell you, right, first of all, what you notice is most of these are southern states. Of course, this part of the South isn't really touched, and if you consider that the South, that's also not touched. I didn't point at Missouri, but who knows. Well, what's actually going on here, what it turns out these states have in common is, and West Virginia is your hint, is that these are poor states. These are states that don't have a lot of money, either from income or due to tax revenue or whatever reason it is. These are states that don't have a lot of money. So one way you can know this is, of course, Texas is a pretty rich state. It is a southern state, so it's got some things in common with all these other states, certainly Oklahoma, for instance, but it doesn't light up. Also, Georgia's a pretty rich state with Atlanta's economy and Savannah and Athens' economy, and then of course Florida with Orlando and Miami, right? These are all of these states that have a pretty good economy, and I don't know much about this kind of northern South state, but I've heard of some cities up in here, so I imagine their economy is pretty good too, compared again to Alabama and Mississippi, which are often listed as the poorest two states. Probably not followed far behind by Arkansas and West Virginia. And then Louisiana probably makes some good money, but they probably spend most of it cleaning up after storms. Certainly a big one that happened a few years ago that they're still paying for. My sister lives here, and then Oklahoma, also not a very wealthy state. And so what this means, again, in terms of wealth, well, what does that mean? There's not enough money there for people to feel happy? No, the problem is, of course, the things that state money brings into a state. If you scroll right down here, you can see that these correlations are clear, right? States with higher rates of depression, and again, I would say states with lower, income are going to have higher rates of obesity, higher rates of heart disease, higher rates of stroke, higher rates of a sleep disorder, come back to this, and then less access to medical care. All of this stuff goes together, right? If your state has less funding, well, they're not necessarily going to be able to have as many free or cheap clinics for those folks who can't afford insurance. If states have less money, they're not going to necessarily be able to put out as much information into the public about what eating bad or not getting enough exercise can do to you, or certainly not taking care of your mental health, which is what we're really talking about here. And then again, here broadly, lack of education is gonna also make it such that folks don't have a good sense of what's going on with these things or how to help themselves out of it, but just everything else too, right? So mental health care, whether or not this means you're depressed, how common that is, and when, and if you should get treatment, right? Rather than just we should leave it alone. We also don't have the money because we don't have insurance, and the closest free or cheap clinic is an hour away. So we'll just grin and bear it, kind of a thing. So this is really correlated with what's going on here, of course, and then also, this is what we're talking about, but you could certainly put a little bullet down here with these are also going to be the highest rates of depression. All of this stuff folds in together, right? These people are just broadly unhealthy, and that will also include their mental health. So here it just says these are some of the most common reasons, or some of the most common associations, I guess, life associations with depression, access for type stuff, right? Unemployed or recently divorced are going to be the two things that are most likely or more likely to make you suffer from depression. So lastly here, just on this particular chart, I'm not really interested in the medical cost, but this is the piece that I really want to look at, is looking at some of this demographic information with regard to depression. So the first thing that you notice is depression is most prevalent in older folks, middle-aged to older folks. I think that most students, at least in the past, have thought that depression is actually more common for younger folks. that it's usually going to be teens and early 20s that we would expect folks to be most depressed. They're confusing sort of a teenage adolescent angst, right? Oh, and everything sucks and nobody will listen to me, right? We're confusing that kind of teenage angst with a real depression, right? With I don't want to do anything, I don't want to see anybody, right? That's depression. Teenagers can get upset and emo and be emotional and all of these things. College students too, of course. But that's not really depression, right? That's just kind of the natural flow of an adolescent's mood state. But here we're talking about a true depression. And so one of the things, all right, and here's this pointed out specifically, one of the things that I usually ask students is, well, why do you think this age group in particular is going to have the highest rates of depression? It's not the oldest age group, so it's not just that, necessarily that people are just getting really old and getting depressed, right? We could do 65 plus. It's not the youngest, it's not the middle, it's kind of this just over the hill age group, right? And what we usually come up with, right, this isn't necessarily inherent here, but just also from my reading, what we tend to come up with is this is the age in which a lot of things are changing for these folks. This is the age at which they may be losing some important things in their life. We talked last time about how depression is often really connected to loss. So kids are moving out, maybe retirement age, maybe divorce, maybe, all of these things. Maybe you have to move into a new house because you retired and you can't pay for the one that you're in, so you just got to do something smaller, right? Your kids move away, take their grandkids across country, whatever it is. Like all of these kind of changes that really mean that the person is moving into this older, later phase of their life, that is probably what is depressing them, right? That they're losing some of their autonomy perhaps, right? If they're maybe getting closer to the 64, 65 and they're thinking about, should I go move back in with my kids? Should I maybe find an older adult community to live in? These types of things. My kids are gone. I don't really have to take care of anybody anymore, right? And so all of these things are really changing for them. And adults that don't, these older adults that don't find a way to find something to vest themselves in, to invest in, right? Whether that's vacation or something just fun to do, or reconnecting with your spouse, or visiting your grandchildren a couple times a month or something, right? Those folks that just kind of let all those things fall away, or don't have the resources, right, to go visit grandkids, to pick up a hobby that they're interested in, then that is the type of thing that is likely to lead to that type of depression, right? You're losing all of these things that you spent your whole adult life and before getting or trying to get, right? I wanted to get this job, I wanted to get this house, I wanted to have a beautiful family, right? And all of that is not just completely going away, but it's starting to drift away. And so these folks are probably somewhat sad about that. The other thing that I want to look at here, let's do gender first. This should say sex. I have a problem with the misuse of the word gender. Gender is feminine, sex is women, right? Gender is a display of gender or sexual behavior. Anyway, overall, women have higher rates of depression than men. Women are twice as likely to have depression and symptoms of depression as men of the same age, and in particular, 1 in 10 women experiences symptoms of depression in the weeks after having a baby. You know this to be postpartum depression. I should point out, I guess sometimes people ask me about this, postpartum depression is not its own diagnosis. So when we were looking at the depressive disorders, there isn't a postpartum depression. What you tend to do is diagnose somebody with depression because it is just depression. But it's depression of a certain cause, of a familiar cause. And so what you would do is just indicate major depressive disorder, postpartum onset, right? So you would just kind of give that qualifier to designate that that's the type, or that's the cause, or the associated life event with the depression. but it is its own diagnosis. But more importantly, what I'm thinking about here, right, is just this double women being diagnosed with depression about twice as often as men. I really want you to keep this stat in mind because this is going to come up again when we look at suicide, and I want you to think about what that comparison might be about.